Good afternoon, and thank you everyone for taking your time to be here today. People continue to filter in. We are a full house today at 100 registrants, and we'd like to welcome you to our Ask Us Anything Q&A style webinar about long COVID and long COVID rehabilitation. A few housekeeping points to start off. We ask that you please keep yourself muted throughout the webinar due to the large number of people present this afternoon. We appreciate those who sent us questions ahead of time, and we'll plan to address those questions throughout the webinar. We will not be monitoring the chat throughout the webinar, but if we do have time after answering the pre-sent questions, we can answer live questions and ask that you use the chat function at that time to ask your questions then. Another note is that we are recording this webinar as we did reach capacity of 100 participants today, and many more individuals did express interest in accessing the information that will be shared today. So we are recording this, and the video will be available to our website within a few days. We'll start by introducing myself and my colleague. So we'll start with introducing Adam Brown. He is a registered physiotherapist, founder of Cornerstone Physiotherapy, a clinical research coordinator at the University Health Network, and an advanced practice physiotherapist in spinal rehabilitation. Myself, I am Melissa Seifried. I am also a registered physiotherapist. I have clinical experience in orthopedic, vestibular, and concussion rehabilitation, and I am the director of Long COVID Rehabilitation at Cornerstone Physiotherapy. I've provided my email address below here, and I'll reference that a little bit later on in the webinar, but feel free to jot that down. If you have any specific questions, if you're a current or prospective client in our program, you can reach me directly there at melissa.seifried@cornerstonephysio.com. So just a little bit about our program to start off. Our program has been around for about 3 years. Adam and I started seeing patients, primarily physicians and nurses, in the latter half of 2020 while we were in the early stages of the pandemic. While we refer to Long COVID Rehab as a program, we do differ from some of the previously publicly funded group-based Long COVID programs, as our care is typically provided one-on-one, and it's provided by registered physiotherapists. We currently have a team of 16 PTs and growing, as well as an occupational therapist and registered psychotherapist. Our program consists of one-on-one assessment, goal setting, treatment planning, and coaching through the management and recovery strategies we've identified in Long COVID Rehab. We use wearable technology and biometric data monitoring to guide our treatment decisions and interventions. We also have implemented support groups to connect long COVID patients with one another in a supportive setting, which is led by our occupational therapist. Finally, we provide advocacy with our patients' medical teams, insurers, employers, and schools to educate and inform them on this condition and support transitions back to school or the workforce. You can reach us at covidrehab@cornerstonephysio.com. That is our general mailbox for the program, as well as you could reach a member of our administrative team at 416-363-1975. If you have specific clinical questions after this webinar or are still wondering if this program is appropriate for you, you can reach out to one of these forums, as well as directly to me at the previously provided email address, or you can request a 10-minute consultation with one of our long COVID PTs. Quickly, we'd like to disclose some affiliations. The framework for this program was developed in conjunction with physician scientists and researchers working in long COVID. Our affiliates help to keep us on top of emerging evidence, and this provides a layer of safety and medical consultation for unusual or difficult presentations of long COVID. We also have affiliations with the CanCOVE and RECLAIM trials.
Hello.
All right, can everybody hear me okay? Mel, you want to give me a thumbs up on that?
Yeah, you're good.
All right. Well, first off, just thanks everybody for being here. Amazing response when we put this out, and clearly just speaks to the need in the long COVID community for good information and for care. We've broken this talk down into a few different categories based on the questions that came in. And the first one that I'm going to be addressing is sort of the general presentation clinically of long COVID and some symptom questions. Um, to begin with, I just want to provide a little bit of context around our comments. Um, Long COVID is a newer condition, as many of you know, or all of you know. The research has not yet had time to become definitive on almost any question that you're going to provide or ask as it pertains to long COVID. What you're getting here on this talk is our clinical expertise after several years of working with people and staying abreast of emerging research. So our comments represent our current best understanding of the condition, which tends to evolve over time. If you were to ask this group of questions a year ago, the answers might be different, and I would be remiss if I didn't mention that a year from now, they would probably be a little bit different, but this is our current best understanding. So the first question, what are some of the more typical symptoms or ailments of long COVID? Um, COVID-19 enters the cell through the ACE2 receptor, and that is so broadly throughout different tissues in the body that it means that there are over 200 documented symptoms of long COVID. That means that there's an enormous presentation, and that one long COVID patient doesn't necessarily suffer from the same symptoms as another. But the most common symptoms that we see are fatigue, something called post-exertional malaise, which is a very severe fatigue and worsening of symptom clusters after relatively light activity, shortness of breath, brain fog, pain, and a whole host of other symptoms associated with dysautonomia, which is a dysregulation of the autonomic nervous system. And you have a mild case of long COVID. Really, the answer to that is absolutely you can. We have people who enter the program who are unable to sit up in bed, all the way to people who are just having difficulty getting back to some of the higher level activities that they might have, or more stressful activities that they might have undertaken pre-COVID. I think that the severity ranges enormously with long COVID. It's also important, and this will be a theme throughout the talk, that not every patient has every syndrome associated with long COVID. And so the syndromes that we've identified that are within the diagnosis or under the umbrella of long COVID are, some people have POTS, or orthostatic intolerance, meaning that they can't maintain blood pressure and heart rate when they're upright. Others have symptoms very similar to, if not the same as, ME/CFS, or what was previously called chronic fatigue syndrome. Some deal with dysautonomia, which again is that dysregulation of the autonomic nervous system. And others have clusters of symptoms that look a little bit like mast cell activation syndrome or inflammatory allergic type symptoms. And any given long COVID patient may have some of those and not others in varying levels of severity. So who benefits most from long COVID rehab? It's a tricky question. Our approach is tailored to the individual. So on our assessment, we look at a variety of things, but ultimately we're trying to identify which of those syndromes are present and which ones are most limiting for the individual. Symptoms of orthostatic intolerance, POTS, dysautonomia, post-exertional malaise tend to respond reasonably favorably. I would say that the post-exertional malaise is in in the mild to moderate range tends to respond favorably to managing the condition well from a rehab perspective, utilizing the techniques that and strategies that we've identified. Patients who their symptoms are primarily at the inflammatory or mast cell activation end of the spectrum are a little less amenable to rehab in the way in which we're doing it. We don't have as many tools for those sorts of symptoms. And I will say that people who suffer from severe post-exertional malaise, so this is people who do relatively, activity that would have been no problem pre-COVID. And then they'll have that will feel okay at the time, but then several hours all the way up to a few days later, they'll have a crash. And that's what PEM is, severe crushing fatigue, and a worsening of all their symptoms. When that particular aspect of their condition is severe, they tend to have a longer prognosis, and it's a trickier situation in terms of where to start. But we certainly have dealt with those with patients dealing with that with some success. So can a change in bowel habits be a symptom of long COVID? Again, the answer to that is absolutely. Many long COVID patients have changes in their bowel and bladder function. Your bowel and bladder is controlled by your autonomic nervous system, and dysautonomia is a clear feature of long COVID. So other than sleep hygiene, can you discuss insomnia in long COVID? So I can't speak to the mechanism of insomnia, but I can tell you that across the board, people suffering from long COVID do have difficulty with sleep. I will say that sleep hygiene is extremely important and requires real consistency. Everything from autonomic nervous system regulation strategies to the timing of sleep to daylight, sunlight viewing, all of those things are really important. And I also want to make the point that anything that can be done to improve sleep does tend to improve the entire condition. Sleep is part of what we would consider to be the foundation of recovery. It's very difficult to get better from any illness if we don't have sleep, nutrition, hydration, all of those things dialed into the best of our ability. And if people are continuing, despite good sleep hygiene, continuing to have problems with sleep, then we encourage them to talk with their primary care physician about strategies around that. So is sudden sensitivity to sugar and alcohol likely linked to long COVID? Absolutely. Universally in the program, it has been our experience that people have an outsized impact from alcohol. Even small amounts will cause their symptoms to worsen. And so we advise to ideally avoid alcohol, but if that's not the case, then to really limit it. We have also found that it's interesting to have somebody mention sugar, because we've found that using blood glucose control strategies that we've borrowed from the research on diabetes has been helpful to a number of patients. And that we began to go down that road as the research started to note that long COVID has a real impact on the metabolic system and can come with mitochondrial dysfunction in the cell. And so this is our way of trying to control the input side of that equation. And a number of our patients have found that very, very useful. This is true of ME/CFS as well. People tend to have mitochondrial dysfunction, as well as a change in what's called their anaerobic threshold, or the point at which they move from utilizing oxygen as a fuel to create energy for their cells to using non-oxygen pathways. So I'm going to hand it over to Mel now to talk a little bit about post-exertional malaise specifically.
Thanks, Adam. Our first question, your clinic has recognized that PEM or post-exertional malaise is real and treatable for people with long COVID. Why are people with ME/CFS who suffer with PEM left out? Should your clinic not change its name to post-exertional malaise clinic to include everyone who suffers from this debilitating condition? After all, people with ME/CFS were here first. That is absolutely true. And ME/CFS patients who do not fall under the long COVID umbrella are welcome, more than welcome in this program. Early on, we focused more directly on long COVID as we didn't have the depths of experience and knowledge in ME/CFS outside of the context of long COVID. ME/CFS has been identified as having significant symptom overlap with many patients suffering from long COVID, with the primary indicator being the presence of post-exertional malaise. So we did not call it a PEM clinic simply because not all long COVID patients suffer from PEM, and there are many other symptom clusters that we address in addition to PEM. The next two questions we grouped together as they were quite similar. Can you explain how the nervous system is involved in post-exertional malaise? And is PEM strictly dysregulation of the autonomic nervous system or something to do with ATP? So the short answer is that this is not clear yet. We do know, as Adam previously mentioned, that dysautonomia has an impact on post-exertional malaise and that there is some disruption at the cellular metabolism level. The degree to which this is mitochondrial, enzymatic, or neurological is simply just not well understood yet. So our approach to PEM is to understand and identify an individual's triggers for PEM to narrow down what strategies will work best for the individual. Is the focus of this program on pacing/meeting us where we are at? I know some therapists advocate for increasing exertion in ways that can be harmful to those of us with chronic fatigue/post-exertional malaise. I want to make sure that is not the approach here. And similarly, how will physiotherapy help long COVID patients with POTS and/or PEM without exacerbating their conditions? So yes, we are very aware of the history of ME/CFS and graded exercise therapy, and that is absolutely not the approach here. We use wearable technology and take a conservative approach while monitoring symptoms. Exercise is never undertaken without considering symptoms first. And as I said, data from wearable tech allows us to make very small incremental changes while monitoring symptoms and the body's response. When I'm working with my patients, I'm often saying symptoms trump data. And so we use the information to help guide our decision-making, but we put the patient's symptoms first and foremost. So an exercise program would never progress if the person was experiencing worsening symptoms. How does post-exertional malaise or PEM show up in smartwatch data? Are there signs your PTs look for that indicate PEM when the patient is unsure if they have PEM? So PEM typically shows up in biometric data as an upward trending resting heart rate and decreasing heart rate variability, or HRV. And that is the amount of time that exists between heartbeats taken over a period of time. And this is compared against the individual's baseline when they are feeling their best. And this is something that we try to establish with all of our patients at the start of treatment. We caution that resting heart rate needs to be taken at true rest, not just when a wearable device or watch opts to report it. And often this is when we are truly at rest is when we are sleeping overnight, which means we encourage all of our patients to wear their watches 24/7, including overnight. Heart rate variability, or HRV, is only reliable under controlled conditions. So we often recommend in looking at something like waking HRV when it's taken at a similar time and under similar conditions, day over day. It's also important to note that single data points in isolation, like a day where resting heart rate is elevated or HRV is depressed, may not be as meaningful to us as a trend over several days in a row. We often ask our patients to download an app called Visible, which is an app that was created for patients with long COVID and ME/CFS by people with long COVID. It uses technology in your smartphone's camera to take daily resting heart rate and HRV readings in the morning when you first wake up and you're still in bed and haven't gotten up and started moving yet. And it compares them to symptom reading trends that you provide in the evenings over some time to determine if and help you decide if you are tolerating your current level of activity. And it can help sort of guide some decision making around pacing. Post-exertional malaise is the temporal pattern of symptom exacerbation. It is not diagnosed with biometric data alone, rather from clinical history. PEM is quite severe, so patients are generally able to identify if they have it once they understand the pattern. As Adam mentioned previously, it's characterized by very crushing fatigue, as well as an exacerbation of many, if not all, of the present symptoms of long COVID.
Well, all right, I'm going to speak to some of the rehab specific questions. I do want to go back and just highlight Visible again. They're a great organization out of the UK. In fact, their entire team is comprised of individuals who either have long COVID or ME/CFS. So they certainly understand the problem. And what they've been able to create, I think is valuable for people. So first question, for those of us with multiple body systems affected by long COVID, are there some general guidelines to follow other than pacing? First, I want to recognize the frustration that might be felt when you ask questions about long COVID, because oftentimes the answer boils down to it depends. And that's where general guidelines sort of fall down. Long COVID is a big overarching diagnosis that involves likely many subgroups that require a slightly different approach. And so general guidelines are certainly difficult. All long COVID patients tend to have multiple systems involved. And the best first step is really to have an assessment to understand which syndromes within the diagnosis of long COVID are dominant for you. And then we can sort out what strategies are going to be meaningful. In fact, if we were to apply general information as it pertains to increasing activity, say, there would be a cohort of individuals suffering from long COVID that would not respond well at all. And so we have to be sure that we triage individuals in the beginning. There are some general, as I mentioned before, general recovery principles that are true within long COVID and outside of it. And that means focusing on getting high quality sleep where possible, having high quality nutrition, ensuring you have enough nutrition. Sometimes people shut down their nutrition because they're not being as physically active, but forget that their body's trying to heal from something significant. Hydration can be very important, in particular for people who have orthostatic intolerance or POTS. And stress and autonomic nervous system management is also very important as sort of a foundational general principle to recovery. So issues with shortness of breath. And this individual mentioned a couple of different triggers in terms of, tense moments, emotion, also sugary foods comes up again. So shortness of breath is a symptom that has a few different causes. Early on in our journey into long COVID, we thought that shortness of breath might be left over from the acute infection in terms of an actual lung restriction, which doesn't seem to be the case for most people, unless they had a very severe case of acute COVID. So the first step is to investigate the cause. Dysautonomia can cause shortness of breath. Like in that small group of individuals who had severe acute COVID, there may be actual lung restriction. Certainly, anxiety is associated with long COVID, not to say that anxiety is the cause, but rather it can be a consequence. of long COVID, and that can also create shortness of breath, as well as metabolic dysfunction that comes with ME/CFS and with long COVID. So for some individuals, those blood glucose control strategies can help. In most cases, the shortness of breath is related to the individual's total activity or the intensity of their activity being too high. And that creates a sustained situation of shortness of breath. And we think that that's related to the metabolic dysfunction, that they're operating above what their body can create with oxidative respiration. Just like if I were to go and climb the stairs up and down quite quickly, I would start to breathe more heavily in order to blow off carbon dioxide because I'm using my anaerobic system. That's happening at a much lower level. We know from the ME/CFS community and research that's been done there that threshold is lowered in individuals who have ME/CFS. Not only is it lowered, it's dynamic. It can change depending on whether or not they're experiencing post-exertional symptoms. That gets a little bit technical, but hopefully it's not too technical. Breath work is a part of treatment for individuals who've had this problem, and it can be very helpful. It needs to be undertaken consistently. It doesn't just help right away. It does require a little bit of work. The overarching principle and impression that I want to give you is that when the entire condition is managed really well, all the symptom clusters tend to move together. When people are doing well, all of their symptoms tend to come down at varying speeds, mind you, but they do move together. And when the entire syndrome isn't being managed particularly well, all the symptoms will tend to rise. Beyond SALT increase incremental rest, gradual cardio, how do we improve cardiovascular, cognitive, and energy-related issues? And so again, I understand that this is the frustrating answer of it. It depends, but an individual's group of strategies that we choose to utilize with them is determined by their assessment and what syndromes are present for them. For instance, a sodium increase only really makes sense for an individual who has orthostatic intolerance or POTS. It doesn't make sense if we do a 10-minute stand test and their postural position doesn't impact their heart rate, then we wouldn't undertake that particular strategy. Just to review, there are some of the strategies that we use that are commonly used with people who show features of their condition that suggest it might be useful. We have a whole host of POTS and orthostatic intolerance strategies that we've borrowed from. POTS existed before long COVID. We borrowed it from that research and bringing it into this environment. Pacing and energy conservation for some people is really important. Again, both the volume of activity that an individual undertakes as well as intensity ceilings. And that's where the wearable tech really helps to form guardrails for individuals that they can easily follow. If you were to say to somebody, I want you to increase your activity by 10%, well, that's very difficult without having constant measurement taking place. Symptom titrated and monitored exercise when an individual is ready. Autonomic nervous system training that can take the form of breath work. It can take the form of HRV biofeedback. We have some interesting techniques that we use for that. We've mentioned blood glucose control as well. For some people, that's really useful. If you are suffering from long COVID and you've noticed that certain foods, in particular foods with a high glycemic index, tend to worsen your symptoms, that's a good place for you to consider intervening. And then coaching on all those recovery hygiene things that we talked about around sleep, hydration, nutrition, and those sorts of things. Next question. Have you been able to find specific treatment that helps with equilibrium? Here, I'm going to assume that this individual meant equilibrium or like dizziness and that sort of thing. In this case, again, much like the shortness of breath, dizziness is a symptom that can be caused by a variety of different problems. This, dizziness or disequilibrium can be caused by orthostatic intolerance or POTS that can result in a lightheadedness or dizziness. We know that people who are suffering from long COVID have more vestibular dysfunction than the rest of the population, and so we need to screen for that as a cause. And sometimes dysautonomia and post-exertional malaise, dizziness can be a part of that symptom cluster. And so the question is, how does the dizziness behave and what are its triggers? And then we try to intervene appropriately. So it's really important to understand the cause of that symptom and then address it from that point of view. Next question. Do you have a rehab plan for shortness of breath muscle? So, this is a common presentation, shortness of breath. It's interesting if we go back to the question that says, what are the common symptoms? It's practically this question, right? Shortness of breath, muscle fatigue, endurance, balance related to dizziness, headache management, and general malaise. Again, the symptoms themselves don't tell us what's going on. Most long COVID patients have fatigue, some shortness of breath, maybe some pain, headache, but how the symptoms behave and what their triggers are help us to know what to do. And that's why our assessment in the beginning and us getting to really know you and talk through how your symptoms are being impacted is so important in this program. It's also why we can't just simply put out general information that will work for a wide variety of people. So my long COVID is associated with the vagus nerve. Having terrible sleep issues, can acupuncture help? So the vagus nerve controls, or it's the main highway of our autonomic nervous system. So this is what we would term dysautonomia. Some patients have tried acupuncture and found it helpful. Many have tried it and not found it helpful. And this is often the case, whether we're talking about acupuncture, medications, supplements. Some people find it helpful, some people don't. Some people find it helpful for a short period of time and then feel it's not as helpful as they had hoped. Other strategies, though, that I want to highlight. We've had patients have some success with vagus nerve stimulation. So there are devices that can be used for that. We've had very good success with HRV biofeedback, and that's what this little device was that I held up. It's called HeartMath, and it's a constant HRV. It reads your HRV constantly, and then you do breath work with it in order to take control of your autonomic nervous system and to get better at that. And autonomic retraining without the use of that device, using breathing exercises. And sometimes we actually use, for those who can tolerate the activity, we'll use movement or exercise as a sympathetic stimulation for autonomic retraining. Okay. Off to Mel.
Wonderful. All right, I'm going to speak to a few specific questions about our program and some of the logistics around it. With thousands of people affected by this condition worldwide, why are other physiotherapy clinics not recognizing that this condition is real and offering proper treatment? As long COVID is still considered an emerging condition, it is exceptionally challenging to enter this space as rehabilitation providers. Rehabilitation research, as we've previously mentioned, is ongoing, but will not be able to provide us with very concrete advice or protocols for years to come. So we intend to help educate the rehab community on what we are learning about this condition to address the gap, as well as expanding our program, hiring new rehab professionals as quickly as we can, while trying to maintain high quality care already. Currently, anyone in Ontario can access our services, and it's important that all of our practitioners have an up-to-date understanding of long COVID, as poorly designed rehabilitation can easily make a patient's condition worse, in particular in the case of post-exertional malaise and ME/CFS. What are the differences between and how effective are the virtual sessions and in-person sessions, and what are the pricing for each? So I would say we primarily see our patients virtually. There is not a material advantage to be seeing by a physiotherapist in person for this particular rehabilitation approach, because there is not really a hands-on component to this type of rehab. And virtual appointments reduce time and energy commitments from our patients. Our standard physiotherapy pricing applies to long COVID rehab. So assessment appointments are priced at $132 and follow-up appointments at $88. Does long-term disability or LTD insurance cover the cost of long COVID rehabilitation? So this depends upon your plan and specific insurer or adjuster. We do work with a large number of patients on short and long-term disability, and we have been successful at getting some treatment covered by long-term disability insurers. Do you have massage therapists that do home visits? No, unfortunately, we do not have massage therapists that do home visits at this time. Do you have physiotherapy for peripheral neuropathy in feet? So we haven't identified a specific approach for this symptom. As previously mentioned, we tend to see when recovery happens and symptoms improve that they tend to improve in clusters. But if this is the only symptom you are experiencing, then our approach to long COVID rehab may not be appropriate for you. I love this question. Mental health is very important in recovering from this condition. I could not agree more. Depression, frustration, moodiness. How do you deal with this? This is a great question and very important. So we did identify this and have identified this from the outset. And we have an occupational therapist and registered psychotherapist on our team who works with patients one-on-one. For those who would benefit from mental health support. She provides tools and strategies in dealing with persistent symptoms and difficult circumstances. She can help people facilitate some of or navigate some of the barriers to returning to work, returning to school, and advocating for her patients. We also have, as previously mentioned, some group support sessions that are ongoing currently within our fall session. And due to popularity, we will likely continue to make this initiative available in the future. And those support group sessions help to connect long COVID patients and are led again by our occupational therapist, Sam. All right, over to Adam.
Yeah, medication-specific questions. And the first thing that I want to note is that I'm a physiotherapist. And so, I don't tend to give a lot of advice in terms of medication. I can share some learnings with you, but we don't prescribe and we don't necessarily advise. We try to engage primary care for that purpose. We do collaborate with your primary care physician. In the case of POTS, there is a Canadian guideline by Satish et al. In 2020 that has a very good section relating to the use of medication in the presence of POTS and orthostatic intolerance for primary care. So we will often provide those resources to our patients to bring to primary care in case their physician doesn't have a lot of experience with POTS or orthostatic intolerance, which is often the case because before long COVID became common in the community, primary care didn't see a lot of POTS. There are loads of trials investigating different medications for long COVID, as I'm sure many of you keep abreast of. We don't have anything that has consistently shown benefit yet at a level that it's being recommended in the community, but we're just at the beginning processes. Another note just on supplements, lots of our patients utilize different supplements beyond just salt supplementation for POTS. We're not aware at this stage of high quality evidence to support them, but of course, there hasn't been time for that to actually take place. And so we do ask people if they're going to undertake something to discuss it with their primary care, just to ensure that it's going to be safe for them. What we would say is, with all the different supplements out there, we've seen variable results. We've seen people who started on something and found it very, very useful and helpful and decided to continue. And we found others with the very same supplement who have not had positive results. I will say that patients who sit at that sort of inflammatory mast cell activation type cluster, oftentimes a daily antihistamine seems to be helpful for that group. All right. Are there any medical diagnostic tests you would suggest for people who suspect they have long COVID, and what costs are associated? So there is no test for long COVID. There's no biomarker that will tell you that you have or don't have long COVID. It's a clinical diagnosis. In our program, we do a thorough clinical assessment. We do a 10-minute stand test to look for orthostatic intolerance or POTS. But based on your presentation, your primary care physician can order testing based on your signs and symptoms. As it pertains to cardiology specifically, there is a guideline that I was involved in that was published in June. The lead author on that is Quinn, in the Canadian Journal of Cardiology, that helps to inform cardiologists and primary care physicians how to manage long COVID patients with cardiac symptoms. And so that's a great resource to also provide to your medical team. You do not need a positive COVID test or long COVID diagnosis to participate in the program. There were lots of periods of time throughout the pandemic where testing just wasn't available to everybody, and so it's just not appropriate to require that test. So Mel,
Prognosis. This is probably where we got the most sort of similar questions around recovery rate, around the percentage of people that we're seeing recover. And I think while talking about it, we should define kind of what recovery is. So here are some of the questions that came to us. The short answer is prognosis is unknown from a clinical research standpoint. Longitudinal research is still being done to determine the natural progression of this post-viral condition. We can look to other post-viral conditions to make inferences, but we cannot speak specifically to long COVID yet from an evidence stance. We find that when clinical syndromes are identified and appropriately managed, people do have the best chance of recovering. But our experience, and I'm sure anyone on this call with long COVID can attest to this, recovery is not linear. Even when you feel as though you are doing everything right, and your practitioner has identified that you are doing all the good stuff, there will still be peaks and valleys to recovery. Adam and I and our practitioners have seen people recover from the stance of coming to a place where either their symptoms are minimized or eliminated, and they're able to return to work if they were off work and return to pre-illness levels of exercise. The timeline to which this happens very much depends upon the severity of initial presentation. And we do find, and we have noted trends that if post-exertional malaise is present, and Adam mentioned previously, if it's a very severe presentation of post-exertional malaise, meaning there very little activity causes very severe and significant crashes that last longer periods of time, we may expect recovery to be longer in those cases. I think we can consider recovery a blend of good condition management as well as true physiological change in the body. So we track and monitor outcomes using something like the Yorkshire COVID-19 Rehabilitation Screening Tool, which is basically a symptom severity scale. And we have patients complete this at initial assessment and then periodically throughout their work with us to monitor and track changes in subjective symptom reporting over time, as well as we can look at biometric data trends to track progress and physiological recovery over time. So things we might be looking for are improvements in heart rate variability, or improvements in resting heart rate, improvements in sleep metrics, while the person's able to engage in increasing levels of activity.
So research and resources. So we're hearing about research that identifies physical insults to our organs, example, lungs, brain. Where in Toronto can I find out if I've suffered organ or brain damage? And so, it's not available as a patient with long COVID to just undertake scans to go looking for these things outside of a research trial environment. I would say that if you are experiencing symptoms that are troubling, to talk with primary care. Of course, primary care can order tests on the basis of signs and symptoms, and can begin to find pathology that way through the sort of normal pathways. What country in the world is best supporting their COVID long haulers? What are they doing better than us? And what does their research show? So in our opinion, the nation sort of leading the way is the UK. In a variety of ways. Their knowledge dissemination and knowledge translation is excellent within the NHS. They've developed publicly funded clinics across the UK, multidisciplinary clinics, and they have developed central outcome measure databases that are quite large and being used in research. And so a lot of the research that we're seeing or that we're using is coming out of the UK. This particular individual has found CBD to help ease inflammation-related symptoms. Is there any research on CBD for treatment of long COVID? We're not aware of any research that shows consistently positive results with CBD, but we do have patients who have made the comment just like this, that they've found it useful, and then we have others who've reported no effect. Where's the best place to access updated information about best practices for long COVID rehab? So our website is one resource. If you go to our website under resources and just put COVID into the search bar, you'll get any new articles that we're producing. Long COVID Web is a research network that's nationwide that has some good resources available that are patient facing, as well as Long COVID Physio, which comes out of the UK, but has some good information on there. And I think this is you, Mel.
Yes. So we did receive a few additional questions more specific to an individual's unique presentation, and we found it challenging to answer these more specific case questions without having much more information or receiving much more information from the individual. So if you did pose a specific question about your case that was not addressed today in the webinar, we would encourage those who did pose those questions to consider participating in the program for more specific assessment and guidance. And if you're still unsure if you're here on behalf of someone else and you're unsure if this program is appropriate for you or them, we can offer a 10-minute consult call with myself or one of our long COVID physiotherapists to get a little bit more information and make some recommendations that way. It seems though we do have about 10 minutes remaining to answer some additional questions that have perhaps come up as we've gone through the webinar. So I'm going to just flip to the next slide, which has all of our contact information. If anybody is feeling they're kind of done at this point, you can head out, or you can stick around for the live questions. We'll just ask again that you use the chat function. I'll do my best to kind of go through some previous ones and ones that are coming in, and we'll do that for the next 10 minutes or so. Okay. There's some great resources present that have been shared in the chat. Question here, at what stage post-infection do you recommend people come to you for assessment? I'm less than 6 weeks out, but have symptoms still present. So the definition of long COVID, if not everybody is aware, is symptoms that persist beyond 3 months or 12 weeks. But we don't necessarily recommend people waiting until that point to come and see us. We can provide some guidance around getting out of that sort of subacute stage and setting you up for sort of success in terms of potentially managing more persistent or long-term symptoms. In particular, just talking about some of the things to avoid. I know a lot of our patients talk about in their histories starting to feel a lot better and then starting to engage in exercise or travel or something like that, and then experiencing a very significant downturn or exacerbation of their symptoms. So we could be able to establish a baseline and help people incrementally increase their activity while monitoring some of their earlier symptoms. So you don't have to wait until 12 weeks. You can, but if you're less than 6 weeks out, feel free to reach out and schedule an assessment or ask additional questions. Anything you want to add to that, Adam?
No, not to that. I noticed some people were just asking about studies that they could be involved in, so I posted the Reclaim trial, and somebody has asked if they're able to save this chat. Do you know the answer to that? No.
Great question. What I can do as a failsafe is copy and paste the chat, but I'm not sure with it being recorded if the chat will be recorded as well. So if you are interested in having the access to the chat or some of the resources from the chat, just send me an email. I'll go back to the slide with my email address, and I can flip some of those resources or the chat directly to you.
And make them available on our site as well. So I'm going to go to this question. Is your clinic comfortable treating patients who have long COVID, MCAS, EDS, and dysautonomia who had this trifecta pre-COVID infection, but it's exponentially worse? Absolutely. We would take the same approach. We feel that the approach that we take is safe and conservative, and we are familiar enough with those syndromes to be able to take on a patient like that. Somebody, I think, had asked about the best wearable.
Yeah. That was in the same chat. It says, regarding monitors, which wristwatch do you recommend, and your thoughts on the AliveCore 12 lead?
Okay, I don't know the AliveCore 12 lead, but now I'm going to have to go and research.
We will be doing some research.
Most of the people in the program are either on Apple Watch, a Garmin device. Some are on Fitbit. We don't love Fitbit. It's not a great quality monitor, and there are a number of things with the platform that make it difficult to use. My favorite is the Apple Watch for sure. Keep in mind that we export the granular data from the Apple Watch. We're not just using what's visible in Apple Health. The other device that I mentioned is called HeartMath. We have these in the program that we use for dysautonomia to do HRV biofeedback. We rent these to patients in the program for a couple of weeks to see if it's going to be helpful to them, to see if they want to consider acquiring one. Yeah, that's right, HeartMath. And it's called the Inner Balance Coherence Plus is what this is. We should film a demo of this so that people can see it. It's yeah.
I'm just going to go back to an earlier question. Have you noticed any positive results for your program with cognitive symptoms, i.e. brain fog, memory issues? I know this is hard to measure, but those are the symptoms that have most directly affected my quality of life. So you're definitely not alone there. And I would say that brain fog tends to, again, as previously mentioned, exist within a number of the clinical syndromes under the umbrella of long COVID. And when the condition is better managed and things like fatigue and shortness of breath and some of those other common symptoms start to improve, we often find brain fog improves as well. In particular, in the case of POTS and orthostatic intolerance, a lot of people find orthostatic pacing or changing positions, getting out of an upright position, putting your legs up on the wall, doing some deep breathing can help to facilitate blood flow and circulation to the brain, and can sometimes temporarily relieve some types of brain fog. And then again, our occupational therapist, Sam, has some experience kind of working with cognitive impairment, and she can provide some kind of guidelines around even pacing your cognitive activity to help to mitigate or improve the symptom of brain fog. A couple people saying their brain fog has improved through Cornerstone's work. That's wonderful.
I would just reiterate from what Mel mentioned with brain fog. I had spoken about how when the condition is managed well, all the symptoms tend to move together, and that's very much the case with brain fog. Some of the approaches earlier on that we were noticing from insurers asking people to work with individuals was they were trying to use cognitive strategies to manage brain fog, and that wasn't we haven't found that to be particularly helpful when an individual is suffering from brain fog because of cognition. Adding cognitive tasks tends to worsen their symptoms. But when their total syndrome is improved, then their brain fog tends to come under control.
There was a question here about how long the intake session is. So our assessments are typically at an hour appointment, and follow-up appointments are 30 minutes. That being said, sometimes we need to break that initial appointment down into 2 smaller chunks depending on the tolerance of the person, but most people can get through the initial intake, which is 1 hour long.
Somebody was just asking if the Valsalva maneuver, if that's one we'll explore too, as some cardiologists recommend for certain cases. If the symptom is related to orthostatic intolerance, then the Valsalva maneuver will help. It ultimately is increasing or helping you to support your blood pressure, and it'll help for the period of time that you're utilizing it, but less of a long-term strategy.
So question here, can you hold a webinar regarding pacing? It's easy to tell someone to pace, but I live alone and have made many pacing plans and can never get my daily calories under a budget. Yes, we could easily do a 60-minute webinar on pacing. And to be honest, that is one of the fundamentals that we help coach our patients through. There's no one right way to pace, and it really is, as we've really said before, so many times it really depends on the person and the ways that they need to pace and the amount of activity that they can basically tolerate day over day. And that can change day over day, which makes this condition extraordinarily frustrating to both treat and have, because we don't always know if a budget one day is appropriate the next day, but we do our best to try to find those limits with our patients, in conjunction with our patients, in order to give them the best chance to stabilize their symptoms and their syndromes, and then help to build a solid foundation from which recovery can happen. And there's fewer downturns and a more consistent upward trajectory. So yes, we will consider doing a webinar on pacing alone.
I just wanted to say that, the term pacing sounds very simple, and it's anything but simple, because people need to pace their total activity, their intensity of activity, their emotion, their cognition, sometimes their amount of time being upright at any one time, and their amount of time being upright throughout the day. And so there's a lot to it, and it often takes people a little bit of coaching over time to get to the point where they can see all of the inputs that are impacting where their symptoms are at any given time. So pacing is surprisingly complex.
How can we find out about future webinars? So we generally will advertise them on our website, cornerstonephysiotherapy.com, under resources, as well as you can follow us on Facebook and Instagram, and we will generally post webinars or events and blog posts and things like that. Adam and I are constantly working on educational resources that can be patient-facing, and we will typically share those on all of those platforms. So that would probably be the best way to find out about future webinars. If you are a current or prospective patient, we do have a mailing list as well, and we'll send information about different events and things we're hosting to our database as well.
For those of you who are already with Cornerstone, I just really want to thank you and thank everybody who's been on here, because it's just become so clear as you look at this chat that people who are suffering from long COVID really need to talk to one another, and they really need to hear from one another, because you guys are on the front lines of this condition. You know a great deal about the condition, often much more than the individual you're speaking to who has a healthcare professional designation. And so it's really heartening to see people posting resources that have helped them, and I hope that that some of you are able to find some real help with your condition through that today.
Yes, thank you all so much for taking the time out of your day to listen to us speak, ask your questions. Please feel free to reach out to us through any means if you have additional questions, want to share resources, or have discussions or collaborations around long COVID. And if you aren't a current patient with us and you're interested in joining, we look forward to meeting with you and working with you and helping you through this.